So, just to ask the audience to get myself know what is doing. How many are doing pilonidal sinuses? How many are doing flaps? How many are doing minimally invasive surgery? So we got to raise that minimally invasive to the flap level and maybe bring the flap level down. So is the case when you're doing minimally invasive surgery. Unlike when you're using the blade, you need to know the whole thing about the system, and you need to have a backup plan like I had one. So it is simple fixes to complex challenges, and complex challenges are usually simple if you think about it. So I'm going to be talking about the burden of pilonidal sinus disease in India, and it follows across the world. We have a population of 1.43 billion. Estimated new cases is 25 per 100,000. You have read about it. And that leaves us to 200 to 400,000, 357,000 new cases, of which 50 to 70% are operated. So that's 200 to 400,000 who are actually operated. Incision rendered, open incision, flap surgery, abscess, and thyroid. But the realistic incidence is much higher. There are many people who just don't turn up to the surgeons, and that's 350 to 600,000 per year. So it's time to standardize, innovate, and time to deliver better outcomes. Why is it so frustrating to do a pilonidal sinus? Because it's a simple disease, it's a benign disease, yet to the best of your effort, there is a recurrence. High recurrence rate, these patients are younger, they can't take time off from work, numerous operations have been done, and there's no universal agreement. There are more than 100 operations for pilonidal sinus disease, maybe because none of them are perfect. So why do operations fail? This you need to keep in mind every time you're doing it. Misfits, especially for endoscopic procedures. Residual cavity, midline move, persistent hair, deep nasal cleft, premature closure, poor post-operative care. For me, I disregard deep nasal cleft. For everything else, I make sure it doesn't happen. So what we need to change? Traditional wide excision images we should change. Large wounds, prolonged dressing, delayed return to work, and recurrence despite radical surgery. So what was the point of doing such a radical surgery for an innocent pilonidal sinus? Maybe because we were taught that way, but maybe we need to change. This young girl who was about to get married and go to States couldn't go because after this pilonidal sinus she has an abscess, and at the nasal cleft down below near the anal canal she has a wound where all the hairs are going in. The problem in the pilonidal sinus disease is often not inadequate excision but excessive surgery. The line is excessive surgery. The change, minimally invasive pilonidal sinus should be the first line of treatment for pilonidal sinus. Trifine, EPSET, laser, Vallops, that is E-Silac. This is for young working population who want a quality of life cosmesis, early ambulation, day care surgery. So these cases, are usually done under local anesthesia. So what is the evolution of pilonidal sinus surgery? From 1833 to 1900, we talked about ANS syndrome, IND, open excision, painful healing. Jeep disease, World War II, acquired muscularization. Radical excision was there from 1950 to 1980. And 1970 to 2000, we had these flaps, which we still do. 2000 to 2010, trephines came in. Yet those who were doing flaps are still sticking to flaps. 2010 onwards, endoscopic era came in. That's EPSET. And 2015, combination of Silac and Vallops. And this has stood the test of time. I have documentation from 2011. They do extremely well. And now I'm going to be talking about minimally invasive surgery in pilonidal sinus. So Dr. Singla, who was there in the audience, he made this beautiful classification. And why was it made? We already had so many classifications. It was made to address people who are doing minimally invasive surgery. So P1 meant you can do the endoscopic surgery. P2, I'm coming to it. P2 meant you can't do it because the wounds are large in midline. And recurrences you can do it provided there is no large midline wound. So we know P0 and PM, we don't do anything. For abscess, you do a lateral drainage and pick the pits. And P1A, that is lateral sinuses or midline sinuses, but they're singular and multiple, but no gross open wound. So P1A and P1B. So you see all the pictures down there. So they can be even complex, but you can do them endoscopically and by laser. And P2 is when you have a large wound in midline, and that's when you cannot do these minimally invasive procedures, best to leave them alone. And P1R, that is recurrence, small recurrences, and I've already shown you these recurrences. And when the wound is large in the midline, you should refrain from doing it. So what I say is depth really a problem? So I'm measuring the depth, and here the depth is 1 centimeter. A 30 years old male operated 4 times, rhomboid flap in India, recurrence, U flap in Netherlands, recurrence, excision and laid open, recurrence. So this will keep going on. And fortunately, I did minimally invasive surgery. He came after 3 years and I said, oh God, I think it's recurred. He said, no, I've come for abdominal pain. I was so happy just to learn that. So Trefine and EPSET and laser, it healed 4 years, last seen in February 2025. So when we are dealing with sinus, we need to know the natural history. We don't know and we're jumping in. So normal follicles become stretched, become infected, acute abscess, chronic abscess, and epithelial tube. So this epithelial tube is an important part where I want to stress. If you can take the epithelial tube out, you can just get away by doing a minimally invasive surgery, which would take 10 minutes, and the patient has a very high success rate. It's 83% at 10 years. That's a very good success rate down the line. So you need to see the pilonidal sinus and you need to mark it. We have to up our way of doing things and we need to put it on our files. Okay, this is the natal cleft and this is the navicular cleft, and we need to mark it. Is it in midline or is it outside the navicular area? So what do we do in pilonidal sinus? We have 2 options: excise or don't excise. I'm going to be stressing on don't excise. In excision, we know healing by secondary intention, primary closure and flaps. We also know in primary closure, when you do midline, it has a very high recurrence. And flaps, you have 3 plus lots of other flaps, and they do quite well if you do it well. But there are some things which are missing, and do you really need to do a flap? If it's an open wound, yes. Then we have no excision, minimally invasive, Trefine, EPSET, and laser. Trefine can stand on its own. So what I'm saying is, do away with this in red. We should stop doing it. I've seen in government hospitals in India where the workload is so high, unimaginable. The junior most surgeon does it and they just excise and leave it open. That's all. That's not the way, because patient come after 6 months or 1 year, it's still open. It doesn't close. So bulk of my work is recurrent pilonidal sinus who are not ready to go back to the surgeon. They said, no, we had enough, 3 months of torture, we're not going back there. And you see them. And you see where the recurrences are. And then not only Limburgs, then you have after Bascom and Limburg, the first one. The second one after Limburgs, the third was after Z-plasty, then midline, after midline closure, and after double VY-plasty. So the midline closure, I sent this to my friend, Dr. Pradeep Sharma, who's there in the audience. because I don't do flap surgeries. So how do we do it? Trephine, Epset, laser and Vallops under short GA, just enough sedation to give local anesthesia, 2% lidocaine with adrenaline and 0.75% ropivacaine 15 cc. So trephine, coming to the simplest one and the most useful one. And we have to use trephine before laser and before endoscopic surgery. That if you do only trephine, the disease-free probability is 93.5% at 1 year and 86.5% at 5 years. So Dr. Gibbs had done a study on 1,358 patients. So what is it? It is this epithelial tract tube you want to take out. So you keep the trephine on to that opening, external opening, take methylene blue, dip your punch in the methylene blue, and you have a 1 millimeter circumferential margin over the hole, and just punch it down. Put a probe inside and punch over it, and you will get this whole tube. You can see the picture in the bottom. The tube is come. This is the tube which comes out. So once this is out, you don't need to touch it anymore. You don't need to burn it. So this is how it's done. Local anesthesia is given, and you have the punches, and you have punched it. Now you can stop your surgery here, or you can go forward. If you're staying in a place where you don't have the laser or the endoscopic endoscope, then you can do it by just doing trephining. The second was by Dr. Minro in EPSET, endoscopic pilonidal sinus treatment, and you've read about it, you've probably done it. It had a mean multi-centric trial showed 94.8% with complete wound healing. And the time of healing was 26 plus minus 10 days. So the punch is done. You've taken out all the bits and all the secondary openings, and then you put in the scope and look inside. And you clean it. What are you looking inside for? You're looking for hairs. You have to remember, even a single hair inside and you burn it, is going to break up into multiple pieces, get embedded in the wall, and be a focus of infection on the patient's life. So you need to be very clear about it. So removal of hair is what most important. This patient had a pilonidal abscess, so I put the scope inside, and in a pocket on the wall, there was hairs rolled up. And this hairs rolled up, when you take it out, you have to be thorough in taking it out. And surprisingly, when the hairs are out, you should always measure the length of hair. And that will give you an idea. This was 4.5 centimeters, and believe me, there's no back hair which is so long. It's the occiput hairs which are going in. So any hairs broken from anywhere will land up with this. And healed abscess wound in 14 to 21 days. Looks really good. You have just used the openings which were already there. Then laser comes. This was by Dr. Papas, 237 patients, and his healing rate was 97.89% after 2 times. First time healing was in 214 of 237 patients, and they did it again in the second group, and you have a high healing rate. So what does laser involve? It involves a 1470 laser machine and a radial fiber. The ablation is at 10 to 12 watts per millimeter per second, and it's on withdrawal. And the withdrawal has to be steady. You can't stop between, and you have to go through. Now, the problem people are doing is they're just doing it in, putting it in, taking the whole thing out, and they just stress the patient. That's not it. You need to cure it first. You need to put a laser in, then you need to cure it again. Put a laser in again and cure it. Your results are going to improve. Do not laser the wound edge, because you already refined it, you already taken out the bad portion of the epithelial tube, so do not do that. So, laser in pilonidal sinus. On the left, you see what it looks like a scope, and on right, you're using the laser fiber as it is. So, this is the laser fiber inside. After cleaning it, and you see the burn, I put the light off so you can see how the laser actually looks, and that's the burn. And then you can see the skip areas if you're doing it endoscopically, and take care of the skip areas. On the right side, you're doing it, you've got your goggles on, you have to press it, you don't want the light to go into your eyes. So this is a young 24-year-old girl who has a very bad pilonidal sinus, and started antibiotics 1 week before, and when she comes, we curate everything and dry the openings, and that's when you railroad the laser fiber into the tracts. You need to railroad it because it can get stuck. If it gets stuck, you pull it out, the top half, glass half, comes out and stays in the tissue. Then you have another surgery and try to take that out. So this is at the end. So Vallops is a combination of endoscopy and laser. And This is with Dr. Kamal Gupta. A study was done and our success rate was 95.3%. So how do we do labs? Sorry about that. So if the patient is prone, the buttocks are strapped, and you want to take a photograph before you actually do the procedure. Why you need a photograph? Because you are going to miss the pits. Believe me, you will miss the pits. Because I made it a habit, I see more pits than the naked eye. So here in this patient, he had a pit which looked innocuous. I was not going to do it, but I said, no, we need to take it out and see what's going on. And it's always a surprise, you see the hairs coming out from there. And had you left it because it looked innocent and it was only seen on the mobile, that you would get this problem would occur. So take out all the hairs, make sure the hair is out, otherwise it's not going to help you. The scope has a different handle than a warp scope. The handle is facing upwards. And go inside, clean everything out with the grasper. The grasper is very delicate, you need to be very gentle with it. But do take all the tissues out. And then this, I put the probe in and I put an infiltrating tube over the probe. And through that I put the laser fiber and come out on the other side. While you're doing the laser, if you leave it like that, many areas will get put behind. So I keep a gauge piece and press on it. So the whole sinus tract comes in contact with the laser fiber. And then this is the ablation you need to do. And you need to do thoracurating afterwards. And then the brush, central brush, put it inside and brush it well. And when you see the skip areas, that's when you go back with the laser with the endoscope and do it. Now endoscope doesn't need to be the fistoscope, it can be a histoscope, a pediatric cystoscope, or a nephroscope, whatever you have, any scope. Get an idea of how it's going to be done. Multiple midline pits are sometimes a problem, and you see how many pits this patient has. And this is the marking I do for local anesthesia. After giving anesthesia there, I mark the pits with methylene blue. And take them out. With a fine forceps and fine scissors, take each of them out. Each is a very important part, as we said. Epithelial tube needs to be taken out, otherwise it's going to cause havoc. So I keep doing it for the whole. And when you come out with this, you see hairs coming with the laser fiber. Even though we looked for it, we did it, I don't think the endoscope was available. That's why I was more worried about it, that it has to be thorough. You need to do a thorough job, and this is how it looks in the end. After you curate it thrice, and then give a wash with argent oxide and clean it. And that's in the end. Prone position for a patient who actually fought with me that I want endoscopic. This was an era 2014. And this girl was a daughter of a doctor, and she said, no, I saw online that you do it endoscopically. I said, but your abscess is so small. I mean, there's no place. But surprisingly, that inside there was a big cavity. And everything was done by endoscope. Everything cleaning was done. The ball tip cautery was used, and everything was washed. And then hydrogen peroxide was put in, and then we see the tract, and then this is how it was. And this is after 6 years. She was married, and she came with some other problem, and I took the picture. So abscesses, you can do the abscesses. What you need to do, remember, laser has no role in the abscess cavity. But laser has the role in the tract that is from the primary pit to the entrance of the abscess. So the abscess is first you punch it, you curate it, you punch the openings midline, and then put the scope inside. With the scope, look inside. And then you can do the laser like that, or you can do through the scope and see the cavity. This is post-op, pre-op, post-op, 5th day, 10th day, and 20th day for big abscess which healed. So recurrent pilonidal sinus, patients are not ready, and what you need to know is the hairs are going from inside, from below, the wound below, and you need to take care of it. So, just showing you how it was done. And she came after 3 years, and the reason she came was she wanted this scar to go away, but the wound was well. So, audience poll, this is for you, for all who are listening. What contributes most to the recurrence of pilonidal disease? So you have to say ABC. A, residual cavity. B, missed pits. C, hair. D, midline closure. E, poor follow-up. So which one?
B and C.
B, missed midline pits. Anybody else?
Hair.
Hair. Okay. Okay, this is the poll after. Midline closure is number 1. Highest quality evidence, RCTs and Cochrane. Missed midline pits is number 2. Persistent hair is number 3. Residual cavity is 4 and poor follow-up is 5. If you ask me, poor follow-up is also a big factor because patients have a lot of hairs and they don't care of it. Poor hygiene is there and you wonder why they're doing that. So midline closure, highest quality evidence for people who are operating by flaps. So the portion which comes in midline, that's the portion you have to be worried about. If the operation is minimally invasive, then missed midline pit come as number 1. This is persistent pits, residual epithelial tract, and treated secondary openings, rather than failure of technology. Here, is it necessary? It is, but not sufficient. It initiates the disease. Persistent hair contributes to late recurrence, and laser hair removal safely reduces recurrence after surgery. But you can also shave it, and you can do a depilation, or you can use creams. Residual cavity may be there. You need to take care of it. At least it can be managed post-op by cleaning it. Poor follow-up, delayed recognition, persistent disease, missed opportunities. I'm coming to the end. Teaching points. What do all the 5 options have in common? Anyone? The answers, you'll be surprised. Every one is preventable. So it's in our hands to make sure that doesn't happen. And the first picture I want to show you, please take a picture with a mobile. That's the radial abscess, midline, hairs, and then deep nasal cleft, residual cavity, and post-op care. So, MIS, implant sinus, yes, it works. And if you're not doing it, maybe you should start doing it. Take it up. Thank you so much. We have a conference in India in September. It's a great colorectal conference. If you are interested, please do come.
Thank you, Professor Mital. Next speaker, we have Professor Zaidi Zakaria from Malaysia, from University of Science Malaysia, and he will speak